GNC, I think it's General Nutrition or something like that. And
Mm-hmm.
it was absolutely mind blowing. I would hypothesize that most doctors do not walk through there, but there are extracts from animal thyroids and animal adrenal glands. And of course, these contain hormones. Those are real hormones, and that they're just not purified, they're just desiccated. So you have no idea what you're getting and how that is going to influence your therapy. I had a patient one time who was taking pregnanediol because it was thought to be some sort of health supplement. And that, of course, gets metabolized directly to progesterone. We could not understand why every time we tried to do a frozen embryo transfer, she would show up and have elevated progesterone levels. So
Wow.
we kept canceling her and said, "Oh my gosh, is she ovulating? Does she have congenital adrenal hyperplasia?" And finally, of course, in retrospect, we should have said, "Why don't you give us a list of all the supplements
What you're
you're
taking.
and then we'll figure it out from there." So yes, they're not harmless. They're not harmless because they cost money, and especially if you're waiting because somebody told you that you need to really get tuned up and get 3 months or something like that of an unproven therapy, that could potentially be very harmful.
Hi, it's Lisa Schumann, just popping in for a quick second to say hello. If you haven't been here before, then you need to know that we are really focused on trying to get you the help that you need. If you've been here before, you know that already. And to that end, today, you're going to have a fantastic episode ahead of you. You are going to get so much information about IVF, about donor conception, about what supplements to take, what not to take, what treatments to use, what not to use, all from someone who is really a leader in this field and can give you the evidence-based information, not just the popular information, on how you can help yourself in your process. So stay tuned. You're really going to love this episode. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome to another episode of the Building Your Family podcast. I am so excited and admittedly a little starstruck today because I'm going to introduce somebody who's really amazing to you. So if you work in the field of reproductive medicine, this guest needs no introduction. If you don't, I will kind of explain to you what you're going to see today. So, you know, when you go to a movie and you see an actor and you think, oh, that person looks familiar to me, and then you Google that person and you see they've had 1,000 movies and they've produced things and they've directed things and you think, oh my gosh, I can't believe this person has done so many amazing things. Well, that's what you will see if you Google Dr. Paulson, who is our guest today. He is an incredible person and has done so much to advance the field of reproductive technology. So I'm going to tell you just a little bit about him because I could talk all day. His resume is a mile long, but he is the director of USC Fertility. He's been with the practice since 1986. He's also a professor of obstetrics and gynecology and the chief of the Division of Reproductive Endocrinology and Infertility at the University of Southern California Keck School of Medicine. He's won many, many awards. He is also the author of Rewinding Your Biological Clock, and he has previously served as the president of the ASRM, the Pacific Coast Reproductive Society, the Society for Reproductive Endocrinology and Infertility, the Los Angeles Obstetrical and Gynecological Society, and is also past examiner for the American Board of Obstetrics and Gynecology, and currently is the editor-in-chief of Fertility and Sterility, which is our journal, and the past deputy director of that journal as well. And so there's more and more to say, but I won't. I will just tell you that when I saw Dr. Paulson last, we were at the donor egg meeting together, and he was introduced as the president of everything. So I think that sums it up. So thank you so much for coming, Dr. Paulson. I'm so delighted to see you and to have you here as our guest.
My pleasure. Thank you for having me.
Also, by the way, I want to thank you. For those of you who haven't seen, I'm so delighted that he endorsed our book, my book with Dr. Leanderis, as you can see right here. He was very kind and generous, and he's also going to share with us much of his wisdom and insight today. And we're going to start with a topic that's near and dear to my heart, which is the way in which the fertility industry is growing in some ways that are not so helpful to us. So I speak a lot about how expert advice is really important. Research-backed information is really what you need to look at when you're pursuing fertility treatment, not just because it will help you, but because also if you go in the wrong direction, you can end up spending more time and money than is necessary. So I'd like to start by asking Dr. Paulson about that. What do you think about that? I know you've written a few articles about this topic.
Yes, well, I'm very frustrated by the fact that our field is really allowing itself to be infiltrated by all of these unproven kinds of therapies. They're generally supplements. So you say, well, what's wrong with supplements? Well, there's not much wrong with supplements unless they're really expensive. And it's also a problem if somebody says, you better be on the supplement for 3 months, that'll improve your eggs. And so you better wait for 3 months before you go on to your fertility therapy. So that's when I get upset, because that means that somebody is losing 3 months out of their biological clock while they are subscribing to some therapy that is unproven and in general not efficacious. So it is a problem. You know, you said fertility industry. We always make a huge effort at the ASRM to call it the field of infertility therapy, as opposed to the industry. And we say, you know, the cardiologists don't call themselves the cardiology industry. They call it the field of cardiology. So we try to do that, but you're exactly right. It is an industry because people are trying to sell every kind of gizmo that they hope will be marketed and will resonate with the patients, and that they will demand it from their doctors.
Yes. And so, as you said, time is lost. And for people with ovaries, we have to worry about that. But also, there are some contraindications to using some supplements, right? Some things can actually hurt, not help.
Well, I have to tell you, I walked through the store. What is it called? GNC, I think. It's General Nutrition or something like that. And
Mm-hmm.
it was absolutely mind blowing. I would hypothesize that most doctors do not walk through there, but there are extracts from animal thyroids and animal adrenal glands. And of course, these contain hormones. Those are real hormones, and that they're just not purified, they're just desiccated. So you have no idea what you're getting and how that is going to influence your therapy. I had a patient one time who was taking pregnanediol because it was thought to be some sort of health supplement. And that, of course, gets metabolized directly to progesterone. We could not understand why every time we tried to do a frozen embryo transfer, she would show up and have elevated progesterone levels. So
Wow.
we kept canceling her and said, "Oh my gosh, is she ovulating? Does she have congenital adrenal hyperplasia?" And finally, of course, in retrospect, we should have said, "Why don't you give us a list of all the
What you're
supplements you're
taking.
taking, and then we'll figure it out from there." So yes, they're not harmless. They're not harmless because they cost money, and especially if you're waiting because somebody told you that you need to really get tuned up and get 3 months or something like that of an unproven therapy, that could potentially be very harmful.
Yes. Yeah, that's so helpful to know. And I think it's so hard, right? People feel desperate. It's so hard for them to say, okay, well, I'm just going to have to go straight to my fertility doctor. They don't want to admit that to themselves. Or once they're in fertility treatment, they want it to happen quickly. And they think that the headstand or the supplement or the yoga pose or what have you is going to be their answer just because their friend was able to take this medicine and now they're able to get pregnant. It may not be that they took the supplement or stood on their head or whatever it might be, right?
So as near as I can tell, Lisa, I keep trying to analyze why this keeps happening. And the principal problem, of course, is that success in our field is still intermittent. So as you and I were talking before the show, the success rate per embryo transfer, of course, has gone up just dramatically. And we're transferring single embryos and getting 60%, or perhaps at worst, if you have a euploid blastocyst, you have at least a 50% chance of producing a pregnancy. But that then elevates expectations on the part of patients. And so they fail once and then they fail a second time and they say, well, something must be wrong with me. No, you just flipped a coin and you got tails twice. It could still be heads next time, 50-50, but they really
Yes.
want to know that they're doing something different. And that opens the door to these kinds of unproven therapies. And then the doctors say, well, I read about doing an endometrial biopsy. We should be looking for endometritis. Maybe we should be trying to culture the uterus. All of this is just nonsense, but they do it. And then, of course, if it works after that, by chance alone, that patient will not only will she attribute her success to the very last thing that she did, but she's going to call her good friend who's also doing fertility therapy and said, I figured it out. You have to do XYZ, and that is
Yes.
going to make the difference. So that's a huge problem. That's a huge problem. And that's just one part. The other part, of course, is that IVF is very expensive. And if the next treatment you're going to do costs $10,000 and somebody says, well, I don't know if it's going to make a big difference, it could increase your success by 20%, and it costs $1,000. And you say, well, if it increases my success by 20% and it's $1,000, that seems cost effective. So I better do that. And they're doing endometrial receptivity arrays, and they're taking estrogen and progesterone, and doing analyses of fluids. All of that is unproven, and I think it's
Yes.
very important that people understand that more is not always better. You have to be patient. It's not a sprint; it's kind of a marathon, and stick with it, and really, really try to focus on those things that are evidence based. Don't waste time and money on unproven therapies and these add-ons that are so prevalent in our field.
Well, I really appreciate you bringing that up. And I think that this is really helpful for the audience. And I hope everyone out there is listening to this because people very often I see on social media will say, that cycle didn't work. Therefore, my next cycle, something needs to change. And if it doesn't change, my doctor doesn't care about me. This is the idea. So, can you explain to our audience that sometimes people need more times up at bat rather than a shift in treatment, right?
That's exactly right. And I do try to say that because you're exactly right. That's the patients will come in and say, well, what are you going to, that didn't work. So what are we going to do that's different? And I try to say, what's going to be different is the embryo we're going to put into your uterus is a different embryo from the one we did last time.
Right.
And even though they look similar and they have the same kind of grading, in reality, deep down, they are different. And the field is not finished. We're not perfect. We cannot yet tell exactly which embryo is going to be the one that implants. So let's go back to the analogy of 50-50. So even if I've got what I consider to be a really very good embryo and it has a 50-50 chance, that's 50%. And if I've got two of those, I can't tell you that this one is better than the other one, or this one will implant and the other one won't, and vice versa. So I try to emphasize that we are going to do something different. We're going to put in a different embryo this time. The preparation that we did is optimized for the following reasons. We had a nice embryo transfer procedure, so we know all of that has been controlled. And so we have to focus on the embryo quality, which has an intermittent quality in its implantation. So that's right. That's right. But it's not easy. It's not easy. And I assume that there are patients that go elsewhere and they go across the street and some guy says, oh, we've got, first of all, you got to take all of these supplements. Stop eating whatever you're eating right now, and
Mm-hmm.
we'll start with teas and with acupuncture, and then we're going to try to do the embryo transfer. And that, of course, is not evidence based, but
Right.
it is certainly emotionally appealing to a lot of patients.
Yes. And also, can you tell us a little bit about the variability in the endometrium? Because, that is a black box for a lot of people, right? We don't really have a lot of information about how to plant that seed and force it to grow.
Yeah, so endometrial receptivity, I've been thinking about it a lot lately because I have a lecture that's coming up And I must admit that we were, I don't want to say guilty, but we certainly started at the beginning of that whole concept. So at the beginning of IVF, people weren't really worried about endometrial receptivity because there was nothing to do. You took the egg out of the patient and then you put it back. There wasn't anything else that you could alter. We didn't have embryo freezing. We didn't have egg donation. We had nothing. And it was really the beginning of egg donation in the late 80s and early 90s that for the first time allowed us to compare one kind of cycle versus the other one and start addressing the question, oh, so here's what it looks like when you're transferring an embryo that came out of someone's body, and here's what it looks like when you're transferring an embryo that came out of someone else's body. So no freezing. We're not freezing it. And that allowed us sort of some insight into this concept of endometrial receptivity, and we kind of ran with it and tried to do scanning electron microscope studies of the surface of the endometrium, and you can still find these pictures of what we called penopods, the little bumps that stick out of the surface of the endometrium at the time of implantation. And so the whole concept of the window of implantation and all that other kind of stuff kind of permeated into the culture. And it took then a long time for embryo freezing to get very good, so that then you could finally control, again, separate the concept of the embryo from the endometrium, to appreciate the fact that really, unless the uterus has been radiated or unless the person has got some sort of lesion in the middle of the uterus, if you have a normal uterine cavity and you have normal thickness of the endometrial lining, which we now measure with ultrasound all the time, and you transfer the embryo, transfer a blastocyst, on the 6th day of progesterone, you have optimized endometrial receptivity. All the rest of it is just noise around the system. And there's several of these tests that are being put out where they are testing for endometrial receptivity, and I don't need to name them, but they are unproven. They do not demonstrate any superior implantation, and they do take time, and some of them can potentially be dangerous. I had a patient who came in and had a result that said that she should start progesterone 48 hours ahead of time. In other words, she wanted to have her embryo transferred on the 8th day of progesterone instead of the 6th. And I said, I'm sorry, but I can't do that. So she said, okay, I trust you. You do it. So we transferred her on the 6th day of progesterone, same as everyone else. And, it was a successful implantation. So that the test that said that she was 48 hours out of sync, that was wrong. And that has been my experience with some of these essays. So endometrial receptivity, is it important? Yes, of course. And yes, you have to make sure the cavity is normal, that there's no fibroids or polyps. Yes, you have to make sure the lining is thick enough. And yes, you have to make sure that you are there at the correct time. That correct time is driven by nature, not by some testing that is being done. That I think that's safe to say. And of course, this is the stuff that we go through when an embryo doesn't implant and the patient comes back and says, what are you going to do that's different? Say, yes, we're going to put in a different embryo.
Right.
We're not going to transfer it at a different time because that would be wrong. That diminishes the probability of implantation.
Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. So I think what we're talking about here also is kind of an acceptance that there's no 100% guarantee in any cycle, in any circumstance, no matter how perfect the uterus looks, no matter how beautiful the embryo looks. There's no way to predict that this will work. There's 100% chance that this will work.
Yes, and it's getting so the patients, I think, still have that expectation, but honestly, the doctors, I would say about 4 or 5 years ago, whenever it was that the ERA came out, the endometrial receptivity array, and they
Yes.
were doing the PGT, and doctors would call me up and said, I transferred an embryo that was PGTA normal, and I did it at the correct time from the ERA, and it didn't implant. What do you think went wrong? And I was shocked, and of course I was sarcastic. I said, "Oh, you mean we haven't yet figured out everything about reproductive endocrinology and infertility?" Yes, we have not
Right.
yet figured out everything yet about the field. That's right. That's right. So our best testing, our best ability to line everything up gets us to somewhere around 50%. It is better than that. It's better than 50. It's actually 60, 65. And in some of the really exceptionally great looking embryos that come from an egg donor, I think you can get to 70%. But I prefer to say it's about a 50-50 shot.
Which, as we said, is a far cry from where we were when we were
Oh,
both
gosh.
starting. So we're very happy to see those numbers.
Oh my gosh. In the dark ages, it was 3% or 4.
Yes.
And you would transfer 5 embryos in an effort to try to get up to that 20% magical mark. Yeah, terrible, terrible.
Yeah. Yeah. It's amazing how far we've come. And yet, I suspect that most patients would say, well, this is really hard for me. And I feel like it should be 100%. I'm spending so much money. I've got time and effort in it. I feel stressed because I'm behind the eight ball. My friends are pregnant. My sister's pregnant. I've tried for so long and it's hurting my relationship. And every day it's all I can think about. And so it feels like the world is coming to an end if that cycle doesn't work. And it's hard to manage the expectations of the patients.
It really is. The good news is that I really think there's light at the end of the tunnel, and that is in the form of mandated insurance coverage that I think is coming through the United States. We now have it in California. We've sort of had it for a long time, but now it's really happening. And I spend half of my time at a county hospital and about half of my time in the private practice clinic, and the county patients still have no access to IVF. So I am
Wow.
waiting for the other shoe to drop. So the bill has passed, but now its implementation has been delayed, and they keep pushing it back. And it was supposed to be January, and now it's going to be July, but it's going to happen. And when you have patients who are, on Medi-Cal or Medicaid, and they will have access to infertility treatment, that is going to be a mind-blowing I think, kind of situation. And that is the light at the end of the tunnel, is that we will be able to we'll have access to care to essentially everyone who wants to take advantage of it.
That'd be incredible. That would be incredible. So while we're on that topic of light at the end of the tunnel, what are the new advances that we can start thinking about looking towards in our world of fertility treatment?
Well, I think we can do better. So, as I told you, I dreamed of the day when we would have a 33% success rate, and now we're at 50 and maybe 60 in some of the younger patients. We're not at 90. So, no matter how good the embryo looks, we're not at 100. So that means there's still something about the embryo that makes it not implant. And I think it should be predictable. There will be parts of it that will not be predictable because we know that everything can be going great, and then you can have some sort of developmental problem later in pregnancy. And analogously, you can have a perfect embryo that will nevertheless not have perfect development after it implants. But we should be able to get higher than where we are today. And whether that's going to be in the in what they call the metabolomics, what it is, if you can look at what the embryo is making prior to implantation, if that'll provide the insight. It's disappointing that time lapse didn't provide that information. Time lapse, that just looked amazing. You put it on
Yes.
a computer, you do time, watch it divide. How is that not totally predictive? No, not predictive. No, it isn't.
Why is that?
Yeah, right. Why is that? You would think
Why
that
is
would be helpful.
Yes.
It's too bad. It's too bad. I mean, it provides some information, of course, but it's not as good as we thought it was going to be. So maybe we'll figure out something else. Maybe there's going to be, I always fantasize about the MRI. They do MRIs for all sorts of things now, for your back and your knee, and of course in the field of fertility, we do MRIs of the uterus, looking
Yes.
for fibroids and all that other stuff. I went to medical school when MRI did not exist, and I have a friend who actually is a physicist that worked on some of the prototypes of that, and it's amazing that they figured that out. And I asked him point blank, well, if you can do that to a human being, can you do that to an embryo? Can you do an MRI on an embryo?
That's incredible.
Right? Wouldn't that be an amazing thing?
Yes.
Yeah, he thought the signal to the physicist, he thought the signal to noise would probably be prohibitive. But stay
Oh,
tuned. So maybe that'll be another way to sort of image the embryo. Wouldn't that be exciting? Or if we could have that sort of
oh yes.
non-invasive genetic test. Yeah. So I think that's going to be. I think that will help. There's going to be a lot of automation that's
Hmm.
coming to the laboratory. It is kind of incredible that with something that detailed and that minuscule, that we still have human beings pipetting by hand and moving embryos
Yes.
from point A to point B. Human beings are not making the chips in your phone. That's being done by a machine that is very precise. So I think the precision microscopic work that is currently being done by humans, I think that will probably be done by machines in some fashion. And whether there is a human being watching it or there's a human being that's controlling it, that's plausible. But I think that has great promise in my mind.
And then what about PGT? Do you think that will change?
Hard to know. So pre-implantation genetic testing is based on the principle that a lot of human embryos are not euploid; they're aneuploid, right? They have the wrong number of chromosomes, and that is true. And it is pointless to transfer those because they will not implant, and they look the same like the ones that are euploid. So pre-implantation genetic testing, the concept of testing the embryo before you put it back, I think is sound. Now, whether the method that we're currently using is optimal, and then because you have to do the biopsy of the embryo and then the subsequent analysis in the laboratory, uh, whether that's optimal, I think that is, still the jury is out on that. There's no question that it has improved dramatically just in the last 10 years, and it's pretty good now. I think we're probably not losing more than about 20% of potential implantations in exchange for the information that you get. But the information is so valuable that it's no wonder that so many cycles here in the United States are using pre-implantation genetic testing. So I think that that's going to stay with us. Again, if we could do it non-invasively, that would be great, or at least less invasively, rather than taking 5 cells off of the embryo. I'm optimistic that will in fact continue to improve.
Yes. Well, I think a lot of people are waiting for that day because there's so many patients that I see who feel very stressed about the fact that all they have left is 2 mosaic embryos or, 2 embryos that have not been tested. And they're concerned because that's all they have left and they're reluctant to use donor eggs. And so I feel like the tide is swinging in a different direction now because there seems to be more of a push to try to use those embryos that otherwise wouldn't be used.
Yes, well, and then they would be right in the case of mosaic embryos. I mean, it is a shame that really at the beginning of pre-implantation genetic testing, they said if it's not normal, then it should be discarded. And it seems very clear to me that there was a lot of embryos that were not used or were discarded that probably had the potential to make babies and to make implantation. So that's where that was. I would be remiss, Lisa, if I didn't mention in vitro gametogenesis, but that's only because it's not it's not really around the corner. I don't see that as a light at the end of the tunnel,
Oh,
because
why?
I'm not sure we're there yet. Yeah, I don't know when that's going to happen. But in vitro gametogenesis, for some of your listeners that don't know what that means, it means making eggs and sperm in the laboratory from other stem cells. So you've heard of stem cell technology where you can take a skin cell, for example, grow it in the laboratory, and then you reprogram it so it becomes what is called a pluripotential stem cell. And that cell can then be differentiated into any part of the body. So, for example, patients who are diabetic, who lose the cells in their pancreas that make insulin, they will hopefully in the near future be able to take skin cells or blood cells and turn those into insulin producing cells that their body needs. And that will be the basis of what they now call regenerative medicine. And the holy grail from our perspective in the field of fertility is that we will be able to take these cells and program them to turn into oocytes and into sperm. And that seems very plausible. It's biologically plausible, but it's very complicated. So it hasn't happened yet. So and it's not around the corner. So I don't know that I would tell people that they should wait for it. I think women who are 30 should still freeze their eggs as opposed to saying, oh, I won't need it. By the time I'm ready to have a baby, they'll have in vitro gametogenesis, and I'll just have my eggs made out of my stem cells or out of my white blood cells. Yeah, we don't know that. So I'd recommend we continue to freeze eggs in anticipation of a decrease, in egg quality from the biological clock, and use those. So egg freezing, I think, is a very logical, very good strategy to try to circumvent this the problem with the biological clock.
Do you think that there's going to be any improvement in egg freezing? I know, that sounds a little silly considering that it was just so hard to get there in the first place. But so many patients freeze their eggs with the hope that they'll work. And certainly, if you're freezing your eggs at 30 and coming back at 40 and they're not working, you're kind of at the end of the road. And so a lot of people feel very, very let down. In fact, there was just a Wall Street Journal, I think, article about that. So do you see any way that possibility could improve, that maybe someday we'll be able to actually look at an egg instead of just looking at embryos and have a good sense of what the potential might be there?
Yeah, that's a tough call. That is a tough call. So first of all, you're right. I think the freezing technology, as good as it is today, was really not as good 5 years ago, and it certainly wasn't as good 10 years ago. So when egg freezing first became a reality, which I would say was in the early 2000s, I think we wrote our paper in maybe 2006.
Mm,
Hard to believe that was 20 years ago, and we were just so thrilled that it worked. But it was still like the old style slow freezing, where
yes.
you lose 20% of the embryos in the freeze, and the ones that come out have a lower implantation rate. It really took a long time for vitrification and the what we call the quick freezing now to take off, and still we get some intermittent results. Eggs that were frozen 10 years ago. I had a patient the other day, she had two batches, and one thawed 10 out of 10. And the other batch, frozen in the same lab with the same technology, I think she got 2 out of 10 from the others. So there's that kind of intermittent quality. And the good news is that in 2025, which is when we are recording this, the technology is really very good. And so if you freeze things now, I think you have a very good chance that they're going to be working for you 10 years from now. So that's the freezing part. Now the other part is the tougher question, which is the one that you asked, and that is, when will you know by looking at the egg that, oh, these eggs are worth freezing or those eggs are not worth freezing? Yeah, that is very challenging. And the only answer that we have in 2025, and it's kind of simplistic, is if you're younger, it's better. And so I used to think that a good age at which to freeze eggs was 35, because, the curve is kind of flat until 35 and then it starts going
Right.
down. And why would you do it earlier than you need to? But I've really changed my mind. I think there's a big difference between 30 and 35 for several reasons. Number one, it's much more secure. Far fewer women have diminished ovarian reserve at 30 than they have at 35. Some women who come in at 35 are perfectly good. Others, they're not so great. So you're better off doing it at 30. And even if everything is great for you at 30 and it's still great at 35, you will get more eggs from that one egg retrieval at 30 than you will at 35. So egg freezing as a procedure is far more efficient at the age of 30 than it is at the age of 35. I would say that most women that come in their late 20s, 28, 29, or something like that, when they freeze their eggs, they generally have enough eggs for 2, maybe 3 babies in the future. That is not the case at 35. And of course, we still have patients who come in at the age of 40 and they say, I'd like to freeze my eggs. I say, okay, but you have to understand that you probably will need 5 or 6 retrievals to have enough eggs for one baby. That is how
Yes. Yes.
inefficient the process gets with advancing age. So long-winded answer, but just to summarize, number one, the freezing technology is much better now. And so the past history of women who say, well, they tried to thaw my eggs and they didn't thaw. Yeah, that used to happen. And number two, just do it sooner rather than later and be done with it. And then you can stop thinking about it.
Yes, absolutely. And just to that point, when we think about what people can do to help themselves in this process, are there other things that you would say are worthwhile for patients to do? People are talking about reducing toxins in the environment, or, we talked about supplements earlier. Are there other things that people can do to improve their chances?
Yeah, well, when somebody really twists my arm and saying, well, what am I supposed to eat? I said, there's no good data on what you eat.
Right.
They said, no, but you have to tell me. Okay.
Yes.
Then what you said is right. Yeah, how about reducing the toxins? I think that's a good idea. Let's reduce the toxin. So the fish thing, for example, is touch and go. I keep reading about mercury in fish, and that distresses me because I really like salmon and they supposedly have high levels, but the magnitude of the effect compared to the benefit of the omega-3 fatty acids appears to be very small. So I was listening to a nutrition lecture the other day, and the guy chanted this little rhyme, and he said, "Seafood, greens, nuts and beans, and a little bit of dark chocolate." And for reasons that I cannot tell you, that resonated in my head, and I remember it. So I will share it with you. I hope you don't get one of those earworms from it. But we're going to do it again. So seafood, greens,
Yeah,
nuts and beans, and a little bit of
a
dark
little bit
chocolate.
of chocolate. Yes.
So in addition to that, I tell patients I think probiotics are a good idea. The body language
Oh,
on the lactobacillus in the vagina, which then gets picked up by the cervix, and then you see some of the remnants of that in the endometrium. I think there is enough, and I call it body language because it's not hardcore data, but the association with the lactobacillus heavy micro biome, I think, is positive. So this is what I tell my patients. You can have a cup of coffee in the morning. That's an antioxidant. Then you should have some yogurt because that is going to give you the lactobacilli. Then salad for lunch and a green tea in the afternoon, and then dark chocolate in the evening to complete the experience. And in between there, get some nuts and beans. So rather than telling people they should cut back on carbs, I tell them that they should do heavy fats and proteins, which is another way of saying cut down on the carbs. But I would rather be positive than
I
negative.
see. Hmm.
But that's, yeah,
That's great.
you
That's
pushed
great.
me out of that evidence-based envelope that I try to live in.
Try to stay in. Yes. Well, that's good for your body, good for your health anyway, right? I mean, what's good for your body, I guess, is good for your fertility.
Reasonable, right? Yeah.
Very. But what about there was I know some discussion about plastics in the follicular fluid recently, right? And so, what do you think about that, and how patients can cut back on whatever they're ingesting in terms of plastics, or should they be concerned about it at all?
Yeah, I don't know. The microplastics, it's just crazy. They're finding them everywhere. And now they're estimating what the weight is in your body. And I know there are people that are trying to measure them in the follicular fluid. I know you can find most everything in follicular fluid. same as you can find most everything in semen. For
Wow.
example, so smoking, we don't talk so much about it. It's not as huge a problem in the United States as it is elsewhere in the world, but people still smoke. And it's probably not the nicotine, but it is the products of combustion that are inhaled as a consequence of the process of smoking, which means, by the way, that vaping also produces a smoke and also probably produces these horrible things. And you can find those products of combustion and these free oxygen radicals everywhere in the body. And when I say everywhere in the body, I mean in the follicular fluid and in the semen. So uh,
Wow.
it does get into everywhere. And so, yes, if smoking was so bad that you would immediately become infertile, then I think we would have lost half of the population of China, right, or France, and so on. And obviously, that doesn't happen. But if you are infertile and you're working towards it, that is the first thing that I think is worth giving up. It is the opposite of sort of doing healthy things.
That's great advice. And what about alcohol consumption? I know people are talking a lot about stopping alcohol, and that's part of our world now.
Yeah, and it's amazing that I think as recently as 15 or 20 years ago, people were saying that if you abstain, I remember reading someplace an article that said if you abstain from alcohol, that should be seen as a risk factor for cardiovascular disease. So
Mm-hmm.
now they've switched over to the other side. It continues to be controversial as far as longevity is concerned. There is some indication that it may be carcinogenic, that people who drink alcohol have a higher incidence of some malignancies. What its impact is on fertility is very unclear. It seems unlikely that it has a major effect, but if people want to give that up, it's fine. People give it up for all sorts of reasons, and it seems like the putative health benefits of alcohol that we heard about 20 years ago, I think those have sort of been erased as
Yeah.
probably being an association with a general lifestyle, or maybe with a Mediterranean. Maybe if you eat a Mediterranean diet, you also tend to have a couple of glasses of red wine, and the benefit is from the diet and not from the wine. But I
Right.
don't push it too much. I think that the general recommendation that women can drink one drink a day and men can have two. I don't know. It's not very evidence based, but if that is a component of someone's life and a component of someone's happiness and relaxation, I don't think there's enough data to say you need to stop doing that.
It's very helpful. It's so helpful, Dr. Paulson. Thank you for all this great information. Is there anything else that we should let patients know?
So I am a big believer in exercise, and I haven't seen the data. I got to find the data on the concept that 30 minutes of aerobic exercise per day is the most antioxidant thing you can do. So we talked about the diet and the seafood, greens, etc. But 30 minutes of aerobic exercise is very important. And the thing that was kind of astonishing in the world of exercise physiology is that over the last 10 to 20 years, people have discovered that the level of exertion is less important than they thought. So people thought that meant
Oh,
30 minutes. That means, oh, I have to go run 3 miles in 3 minutes, or I have to get on the elliptical and I got to be sweating and huffing and puffing. And that doesn't seem to be the case. It seems like even walking and getting up and so on has a large role. So I'm very opposed to sedentary lifestyle, if at all possible. And if you can break up that aerobic exercise into maybe a couple of sessions, maybe one in the morning and one in the evening, I think that's very worthwhile as well. All sorts of health benefits from that, mental health and physical well-being, and no data on whether it'll get you pregnant or not, but it is a general health thing. I think it's a good idea.
and it does also set you up for pregnancy, right? It gives you this ability to carry the pregnancy in it, hopefully in a better way because your body is redistributing weight and all of that, right? It could be really strengthen you for your pregnancy.
Absolutely. I think it's safe to say that we did not evolve to sit on the couch.
No, but some of us are very good at it. My children like to practice that exercise. Well, thank you so much. This has been so wonderful. I really appreciate your time and your wealth of information. You've given us so much. And if people want to reach out to you, how can they find you, Dr. Paulson?
Well, I'm at USC, and so my email is rpaulson@usc.edu. That works very well. But I think if you just search my name, I think the USC website and the USC Fertility website will direct you to our practice in Southern California.
Okay, terrific. Well, thank you so much. And thank you, all of you, for listening. This is really, really helpful information. You won't get this anywhere else. Dr. Paulson is really an icon in our industry, and we're so grateful to have him and so grateful to have you, because you subscribing and you coming is how we keep going and how we keep providing valuable information so you can have a better path to parenthood and a better parenting experience. So thanks for coming, and I will see you next time.
Thank you so much, Lisa. Thanks for this opportunity.
Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.